Hello, everyone, and welcome to tonight's UCLA Psychology Presents on Levering Psychological Science to Make a Difference in the Clinic and Community, Interventions with Breast Cancer Survivors and Community Mental Health for Young People. I'm Annette Stanton, and I have the honor of serving as chair of UCLA's Department of Psychology. It's my great pleasure to introduce our featured professors this evening in order to explore how psychological science is implemented in the clinic and community for youth to adults. Following their presentations, we look forward to taking questions from you, which you can submit through the Q&A feature at the bottom of your screen. Please feel free to submit your questions anytime and note that the chat function is turned off. I'd first like to share a bit about our department. UCLA Psychology is a leading department of psychological science in the nation and the world. We have foremost experts in psychology and neuroscience who conduct innovative and impactful research in behavioral neuroscience, cognitive, clinical, developmental, health, quantitative, and social psychology. We have more than 4,700 undergraduates enrolled in our 3 psychology majors, and our highly competitive PhD program with its 200 graduate students supports tomorrow's leaders in research, teaching, and public service. One of my favorite activities as chair of the department is highlighting the exciting research and education conducted by psychology faculty, along with our graduate and undergraduate students and postdoctoral scholars. Now we'll begin with presentations from our 2 esteemed professors, and then I'll join them to pose your questions. First, I'm pleased to introduce you to Dr. Julie Bower. Dr. Bower is a professor of psychology and psychiatry and biobehavioral sciences. She's also associated with the UCLA Cousins Center for Psychoneuroimmunology and the Center for Cancer Prevention and Control Research. Dr. Bower directs the Mind-Body Research Lab at UCLA and focuses broadly on mind-body interactions in individuals confronting stressful life experiences. She offers our students education and research training in these areas. She is past president of the Psychoneuroimmunology Research Society and has won the Norman Cousins Award from that international society. One area of her research examines how positive psychological factors, such as benefit finding and positive emotions, influence physical health, with a focus on the biological pathways that link positive psychological processes and health outcomes. Another line of research examines immune effects on mood and behavior, including fatigue and depression. Dr. Bower also conducts mind-body interventions such as yoga and mindfulness meditation, which we'll learn about now. Welcome, Dr. Bower.
Great. Thank you so much, Annette. It's a pleasure to be here with everyone tonight. Let me go ahead and share my screen. So let me start today by explaining why, as a psychologist, I'm going to be talking with you today about breast cancer. So as I'm sure many of the audience is aware, breast cancer is the most common cancer diagnosed among women in the United States. 1 in 8 women in the US will be diagnosed with breast cancer at some point during their lifetime. So this is obviously a highly prevalent condition. So let's focus on this 1 in 8 woman. And the medical community, and particularly oncologists, really focus specifically on the tumor. And that's fantastic. They have done a really wonderful job at being able to diagnose these cancers very early and to be able to treat them very effectively. However, as psychologists, we recognize that a cancer affects the whole person, right? Not just the tumor. And this occurs during diagnosis and treatment, but also after treatment is over, after the tumor has been removed, after a woman has completed her radiation, chemotherapy, other types of treatments she may have experienced. We call this the period of cancer survivorship. And we know that women continue to experience many issues during this period. So, what are we thinking about as psychologists? We want to be helping women reduce their feelings of distress and depression. We know that depression, the prevalence of depression, is higher in women with breast cancer than in women who haven't gone through a breast cancer diagnosis. We want to help women manage side effects of cancer treatment. We know that two of the most prominent symptoms are fatigue and sleep disturbance. These can affect women for months and even years after they complete treatment. As Dr. Stanton mentioned, I'm also really interested in positive psychological states. And we know that these can be ignored as women are dealing with the really tremendous stress of going through diagnosis and treatment, and then dealing with this aftermath of the treatment experience. So we really want to help women kind of rebuild and even enhance their well-being, including feelings of positive affect like happiness and joy, as well as feelings of meaning and purpose in life. And finally, we'd actually like to help these women prevent cancer recurrence if we possibly can. And the way we like to think about this is we want to help the women create an environment that is inhospitable to cancer. So we've been really interested in the promise of mind-body therapies to address this constellation of issues. So we've looked at a number of these different therapies, as mentioned by Dr. Stanton. These have included mindfulness meditation, yoga. We've also done studies looking at Tai Chi in breast cancer survivors. But I'm going to focus today on mindfulness. So I'm sure this is a familiar word, at least to many of the audience. But I like to start with the definition so we can think of mindfulness as paying attention to present moment experiences with openness and curiosity without judgment. So that's a really critical piece of what we're thinking about as we're thinking about mindfulness. Over the past several decades, interventions have been developed to help people become more mindful, to develop mindfulness in their daily life. So this isn't only something that Buddhist monks can do, but that everyday folks can be working on. And we became interested in mindfulness when there really was a pretty good body of evidence showing that it seemed to be effective in addressing many of the symptoms that we are seeing in our breast cancer survivors. And that's illustrated in this really important review that was published in JAMA Internal Medicine back in 2014, probably one of the first papers published in JAMA where they're focusing on meditation. And basically what they found in this review was that mindfulness meditation programs were actually quite effective in reducing anxiety, reducing depression, also improving things like sleep and pain. So we thought this could be a really good fit for our breast cancer survivors, and particularly for young women who are diagnosed with breast cancer. So about 19% of women are diagnosed with breast cancer at or before age 50. And as you can imagine, having breast cancer during this time is very, very distressing. Distressing at any time, and particularly for younger women. We see higher levels of depression, fatigue, sleep problems, all of the symptoms that I mentioned earlier. And these young women are also at elevated risk for cancer recurrence. So we really want these women to be living long and healthy lives. And we decided to see if a mindfulness meditation program could help them. So we've done a series of studies testing this mindfulness intervention in younger breast cancer survivors. And I'm just showing you some of the snapshots from the papers that we've published here. But I'm going to focus here on one trial in particular, the most recent trial we've conducted, called the Pathways to Wellness study. So this was a study that enrolled 247 breast cancer survivors at 3 sites in the United States, here at UCLA, at the Dana-Farber Cancer Center in Boston, and at Johns Hopkins in Baltimore. All of these places have robust programs that focus on younger survivors, so we thought that would be a good place to start. All of the women in the study had been diagnosed at or before age 50. They had completed their treatment, but they were still experiencing symptoms of depression. So the program that we've been testing in these studies is called Mindful Awareness Practices. This was developed by Diana Winston and Sue Smalley here at UCLA as part of the Mindful Awareness Research Center. It's a 6-week group-based program, and each week people are introduced to skills that kind of progressively help them develop their mindfulness muscles. So in week 1, you get an introduction to what is mindfulness, and you learn a basic breath meditation. In week 2, people move on to doing walking meditation, sound and body meditation. In week 3, you learn to dealing with physical pain, using mindfulness for working with pain. In week 4, you then move on to working with difficult emotions and also enhancing positive emotions, which interestingly turns out to be quite challenging, which is why they save it to week 4. And then in week 5, people learn skills for working with difficult thoughts, and they also do some relational mindfulness. So they're trying to learn how to bring mindfulness into their social interactions. Week 6, you wrap up and think about how you're going to sustain this practice going forward. So one of the really interesting things about the MAPS program is that it includes both formal and informal mindfulness. So formal mindfulness is what I think we all probably think about when we think about doing meditation. Like, you make sure you're in a quiet place, you sit, you listen, you close your eyes, you listen to a tape or some kind of mindfulness recording, you focus on your breath. So we do all that in the MAPS program, but it also really focuses on helping people bring mindfulness into their daily life. So if I'm going through the day and I'm getting upset about something, if I'm feeling some kind of physical symptom, I learn skills for bringing mindfulness into the moment to deal with those. So I don't have to say, okay, let me go and sit for 5 minutes in meditation. I can do that over the course of my day. So does this program work consistently in our studies? We found that it does. So let me show you some data to support that. So what are you looking at here? This is basically a graph that's looking at changes in depressive symptoms across the study period. So we had women complete assessments at baseline before the intervention, at post-treatment, and at a 3- and 6-month follow-up. So time is here on the horizontal axis. And the MAPS group is shown here in the blue line. Our control group, which is a waitlist control. These women are waiting. They're not getting any treatments over the study period. They're shown in orange. So what I want to draw your attention to is the significant decrease in depressive symptoms from pre to post intervention in the women who went through this mindfulness group. And importantly, their depressive symptoms remained lower, I should say. They're still a little elevated compared to the general population, but definitely lower than the control group, who really didn't show much change over the study period. We also saw significant beneficial effects on symptoms of fatigue and insomnia, which, as I said, are 2 of the really common and just troubling side effects that we see in the context of breast cancer. So significant reduction in fatigue in the women who were going through the MAPS program, and that was sustained over this follow-up. Similarly, we see significant reductions in insomnia over the assessment period. What about positive affect? As I mentioned, part of this treatment is really focusing on trying to engage positive affect and enhance positive emotions. And indeed, we see increases in positive affect in the blue group here, that's the MAPS group, relative to the waitlist control group, as well as increases in feelings of meaning and peace in life. So finally, we are really interested in how these kind of mind-body practices may be influencing the immune system in ways that have relevance for long-term health and well-being. And in this and many of our studies, we're looking specifically at inflammatory activity. We look at inflammation in the context of cancer because we know that it can play a role in facilitating the growth of tumors and perhaps even more importantly, the metastatic spread of these tumors. So we're looking here at expression of pro-inflammatory cytokine genes in immune cells from these women that we collected before and after the intervention. So we want inflammation to be remaining low. And that's exactly what we see in the MAPS group, or the blue group here, right? So we see really no change in pro-inflammatory gene expression, which is a measure of inflammatory activity in the mindfulness group. In contrast, we see an increase in inflammatory gene expression in the control group. Now, we've seen this beneficial effect of mindfulness on inflammatory gene expression now in 3 studies. So at this point, I'm starting to believe that this is a real effect. And we're interested in the possibility that this has relevance for the potential growth and recurrence of women's breast tumors, although that's really to be determined at this point. I want to finish by just sharing very quickly kind of next steps for this program of research. We're really interested in expanding the reach of this intervention. So we've partnered with the NCI Community Oncology Research Program, which has sites throughout the United States, basically designed to test usually medical therapies for cancer patients and survivors. And we have a partnership with NCORE to actually develop and test digital versions of our mindfulness intervention, which we're really excited about because it will hopefully allow us to take this intervention from this, kind of pretty selective medical center out into the community so we can expand the reach of the intervention and hopefully help more women. Thank you.
Thank you, Dr. Bower. Now we will bring on Dr. Bruce Chorpita. So let me introduce Dr. Chorpita. It's my pleasure. Dr. Chorpita is a professor of psychology and psychiatry and biobehavioral sciences at UCLA. His ongoing research is aimed at improving the effectiveness of mental health service systems for children through innovation in mental health treatment design, clinical decision-making, information delivery models, and service system architecture. A past president of the Association for Behavioral and Cognitive Therapies, Professor Chorpita has published more than 300 scientific papers, many of which focus on strategies for improving efficiency and quality in children's mental health systems. And he is the lead author of the Match ADTC protocol, an evidence-based treatment that outperformed multiple other evidence-based treatments in 2 randomized effectiveness trials in 3 different states. Dr. Chorpita served also as the lead developer for the intensive treatment component of PRIDE, a project designed to develop, test, and disseminate effective treatments and training models for lay counselors to address anxiety, depression, and anger problems in adolescents in India. With support from the William T. Grant Foundation, he leads the Reaching Families trial, an investigation to improve the use of evidence in supervision and clinical decision-making, and to improve family engagement in mental health services in low-income communities in Los Angeles public schools, as well as counties in rural South Carolina. Welcome, Dr. Chorpita.
Thank you. Great to be here. I should thank some of the folks who are joining from the East Coast too. I saw some names, people staying up late, so thank you for staying up. And for those of you on the West Coast, thank you for postponing your dinners for now. Hopefully I'll make this worth it. So I work in the Child First Lab at UCLA, and our goal is to really just transform communities and to improve the lives of young people through psychological science. So I'm going to try to unpack that really quickly, to try to talk about specifically what we do. But I want to start, if folks could turn on the chat feature. I know we had it turned off, but if we could turn it on, just to get folks ready. I'm going to do my quick disclosures. Thanks to my sponsors who fund us. I also am a co-founder and board officer for PracticeWise, which is a group that really does a lot to turn these ideas into impact. And they're kind of in the trenches day in and day out doing that stuff. So wanted to mention that as a disclosure. But here, if we can open the chat, I'd love to see if people can guess where this quote comes from. We're going to start off with this quote: this nation, the richest of all world powers, has no unified national commitment to children and youth. The claim that we're a child-centered society, that we look to our young as tomorrow's leaders, is a myth. Our words are made meaningless by our actions, by our lack of national, community, and personal investment maintaining healthy development of our young, by the minuscule amount of economic resources we spend in developing our young, by our tendency to rely on a proliferation of simple, one-factor, short-term, inexpensive remedies and services. So people are aware we're in a children's mental health crisis. And so if you want to take a guess when this happened, you could put it in the chat when this quote came out, or maybe who, or even what country, if you want to take a look at that. I don't see anything in the chat. Everyone's afraid. That's us. Someone said that's us. It is the United States. That is correct. Does anyone have an idea when somebody might have said this? 1983. Well, we're going to go, everyone seems to be either afraid or they actually are having their dinners right now. So I'll tell you, it was, okay, 2009. Someone's saying 2009. That's more possible. So I'll cut the mystery here and say this was from 1969, 55 years ago, roughly. And it was page 1 of the final report of the Joint Commission on Mental Health of Children. So this came out of Lyndon Johnson's work. And then this, I could walk you through a timeline. This has gone on for close to 6 decades. So this children's mental health crisis that we're in has been around for a while. And the reason I start off with this is because I really want to emphasize that I don't, but this is my lab and my colleagues, some of my close colleagues here. So what are we doing about it? I want to emphasize that I don't think that we are any better, smarter, or more hardworking than the literally thousands of people that have worked on this for 6 decades. So what are we doing that's different? We have to do something different, right? We can't just say, let's work harder, or we have a slightly better idea. We must do something different. And I'm going to just talk about a 25-year effort of a start of something different. And I want to focus on 2 ideas quickly. One of them is better stewardship of what is already known. So what do we know already about children's mental health? You're going to be surprised, I think. And number 2, what is the infrastructure we can use to collaborate better? The state of collaboration in psychological science, I would say, is not great. And so I'm going to talk about that just a little bit and try to talk about what we're doing. So on this first one, though, let's just jump in. Producing. So it may be surprising to people. We actually know quite a lot about children's mental health. I get a lot of questions. What do we know? Do we know what works? We really do know what works. In healthcare in general, there's more than 75 big randomized clinical trials. Like, these are big, expensive, multi-year studies. More than 75 published every day in healthcare. And this was 10 years ago. And then systematic reviews, there's so many of these that people write papers summarizing all the studies. 11 of those are published every day in healthcare. It's gone up. Now there's 80 systematic reviews a day as of 2019, right? So we are fantastic. And we're every bit a part of this at UCLA. We produce a lot of research and a lot of studies. So much part of the issue is it becomes hard for people to get their head around them and read them, and to take action based on what we know from them. But we know a lot. My colleague Kim Becker and I are finishing a review where we've identified over 1,000 effective treatments for children's mental health from 1,600 randomized trials. So this is a huge amount of research. There's a lot that works. So the problem isn't that we don't know enough. Of course, we need to do more research always, and we'll get into that. But we're not using what we know. Can we store it well? Yes, we've been at this for 5,000 years. We've gone from writing on stone to storing things digitally. In my lifetime, we've gotten 100 million times better at storing what we know. We will not have any problem writing down what we know. The problem is pulling it back out and applying it. We still use pretty old-fashioned methods. And most of the treatments in children's mental health end up taking the form of a book and a journal article that supports the book and so forth. And I like telling the story sort of in pictures here, where I actually had a student some years ago who got a sense of this right away in graduate school. So this is a student of mine named John, And this is a picture of him in his first year of graduate school, learning a treatment that is supported by science for children's mental health. And then here he is as a second year, learning a few more treatments. Here he is as a third year, learning a few more treatments. And then in fourth year, he dropped out and went to Wall Street and got a job. No, he actually became a professor and began writing his own books. So good for John. But he took these pictures actually to make this point that it's overwhelming to get your head around how much we actually know. So what are we going to do about that? What are the modern ways we can organize what we already know about children's mental health? So I'm going to talk for a minute, and this is where, if you're on the East Coast, this is where people start getting a little sleepy. I'm going to talk about something called structured ontologies. Ontologies are a way of specifying information in a way that is so explicit a machine can summarize concepts. The reason I have a picture of a cell phone, because if you're familiar with cognitive assistants like Siri, if you have something like that on your phone, that's the backbone of how those work. It allows machines to reason about concepts. And it's basically, you can think of it as a way of putting together many facts and observations and summarizing them down into tiny concepts. I have a picture of this report here. I want to mention this. The good news is that very recently, the National Academies of Sciences pulled together a team to look into the potential of ontologies to organize behavioral science and to say we can get more out of the science we have if we use the same things we use in our digital life to search for things like plane tickets and find anything else on retail kinds of things we want to find. We should be able to find facts about behavioral science that easily. So I was lucky enough to be part of this team, worked for 2 years putting this report together. Suffice it to say that this semantic technologies, ontologies, allow us to take millions of observations and facts and summarize them in a tidy set of concepts. So how does this apply to John, right? Let's get back to that. So about 15 years ago, there were 72 effective interventions for disruptive behavior in young children. So if you have a child who doesn't listen or doesn't follow directions, there were 72 different programs. And using ontologies, we could extract concepts and say, oh, well, we can put that all into one pattern here. And if we take a close look, we find that, in fact, about 60% of those effective treatments use a technique where we teach parents a specific strategic way to praise. And if you praise strategically in this particular way, you're more likely to have your child behave in the way that you want and so forth. So John now just needs to learn a couple of things off of this list rather than 72 books that he has to read. Where are we now? We're finishing a review looking at 1,581 randomized trials summarizing over 3,700 treatments for children's mental health. And we can do the same kinds of things. Here, this is a picture of a tree where we can actually factor the entire children's mental health literature according to what looks the same and what looks different. So which problems have different kinds of solutions for different ethnic groups, different ages, and so forth. So we've kind of built this tree, and you can look at the same node as we were looking at before. And if you're really careful, you can see that praise is still on top. It's still the #1 thing to teach families when their children are having a tough time listening. But the other things have rearranged themselves now that we're up to over 200 studies looking at that. So these are nice patterns, but what we know is we need to go from patterns to what we call knowledge appliances, right? Like you can have the best map in the world, but no one really drives with a map holding it up in front of their face, right? You want the turn-by-turn guidance. And what we've been trying to do for 20 plus years is take all of the studies, turn them into a GPS-like appliance, and see what happens if we put that in the hands of a mental health provider or a lay counselor or even a family member and see what happens. And we've built and tested many of these. I'll just mention a few. This one is from about 20 years ago. This graph on the left is basically every child in the state of Hawaii public mental health system getting better over a 3-year period. You see that line going down. Every quarter, every 3 months, the entire state system got better and better at improving kids in the system. That state went from number 50th in the country to one of the very top children's mental health systems in the US in just a 3-year period. we did a randomized trial back then. We did this in Boston and in Honolulu, beating other gold standard evidence-based treatments in a multi-site trial. We implemented the largest service model in Los Angeles County in the public mental health system, getting positive outcomes across 4 different kinds with a single system, 4 different mental health challenges. And that's still going on today. We showed how a single intervention system can outperform a control group based on over a dozen of these gold standard treatments right here in California. This was mostly Southern California. And then delivery of that same intervention system being slightly adapted to be used with children with epilepsy in the UK. And that worked as well. You could see from this graph here. Great news for us, because you saw that quote I started with, children's mental health doesn't get a lot of recognition. This study came out Saturday, and it was on the cover of The Lancet, which is the top medical journal in the world. So children's mental health is getting some good coverage finally, which I was really pleased about. My point here is there are better ways to organize and apply what we know. And so I haven't really been making any new treatments. I've been organizing the thousands of treatments we already have for 20 years. And we've been finding that people really like that better. And it gets great results when you can do that. But we're really still just getting started. Let me talk about the second idea real quick here, which is collaboration. And this is where our field needs a fair amount of work, I would say. So it's easiest for me to explain this by some kind of comparison here. So I'm going to take something that I think was really great that happened in 2012, which was we produced this Match ADTC manual, and we tested it in a randomized trial, showing that it outperformed many other treatments. It was a fantastic demonstration. And in our field, that gets published as a book. Now, we have some fancy ways of making it GPS-like online and things like that. But we still have to publish books around here. And so we published a book with 2 authors, published a study with 10 authors. By comparison, if you look at another big hit from 2012, like The Avengers, you'll see that that movie in its credits has over 3,300 contributors. So I like to sit and think, what would happen to the quality of our interventions if we could have 3,000 scientists work on the same protocol? And that is a dream of mine, to get a system where people can collaborate in that way. That's a big engineering task. It takes things like what we would call plug and play interfaces, meaning whatever you build has to work with everybody else's thing without having to even know who they are. We need to have increased reusability. We do a lot of work, and a colleague of mine just published a paper on this. Most of the treatments that we see that come out as new are actually just reorganizing things that we've been doing for 30 or 40 years. So we reinvent the wheel a lot in children's mental health, and we should be getting away from that and thinking, how do we build on to things that thousands of scientists can participate in? As I mentioned, ontologies are helpful for translating concepts because not everyone uses the same term for the same thing. And at the end, we would have something that feels simple for the participants, but at scale manages all of the complexity. That's why I have this bird flock here. Birds do pretty simple things as individuals, but at scale, flocks can do some really wonderful and complex things. So I could show you graphs of how much people enjoy the feeling of using systems like this, but I actually thought it'd be better to show you this in pictures. So these are all folks from different places over time who are participating in events that have been focused on getting people to be able to share their concepts, their ideas, their tools, their protocols, putting everything in one place and having systems that work together. I'll call out just a few things, like the folks in Germany these are faculty, leading faculty from all universities all over Germany, putting together a curriculum based on these ideas for a nationwide effort in Germany. Great work going on with UNICEF. We've done similar kinds of kits and systems with our partners in India. Of course, pictures right here from LA County, and as mentioned, our work in South Carolina. So lots of folks leaning into this at this point, which I think is great. Baseball season just began, so I'm going to kind of wrap up with a picture of Dodger Stadium. I just want to make the point that designing this way does lead to impact. So why do I show Dodger Stadium? Really, the models that I'm talking about now serve over 40,000 families per year in LA County alone. So we couldn't seat everyone with their caregivers, with the youth and caregivers. We wouldn't be able to seat them all in Dodger Stadium at once, which is how many people are now benefiting from some of these systems. And through our partners, I mentioned PracticeWise in the beginning. We have partners with over 550 trainers worldwide, working with over close to 40,000 mental health professionals in 50 states and 130 countries. My colleague Margaret Crane at Brown University just published a nice paper about this, showing how implementation organizations can really help take ideas to scale. I want to end by saying, let's just imagine this vision going forward. This idea of thousands of scientists building into shared platforms instead of us each building something from scratch, having a robust, dynamic infrastructure to organize everything that we know about children's mental health, and something that can scale out instantly to millions of users and become available to them right when they need to know it. Because there's so many folks on right now who, some of you might be alumni, some might be from the community, I want to raise this one final question, which is, whose responsibility is this? And I ask this because sometimes people walk away thinking, well, you do mental health for children, that's great, that's your responsibility, or you're at UCLA and that you're the folks who are supposed to take care of this. But I just want to urge people to consider, we live in a world where we expect the young people of today to be the leaders of tomorrow and take care of us tomorrow. It really is all of our responsibility, and we all have a stake in this. We are still in a children's mental health crisis, and we need to not be doing just more of the same. Yeah, and even smarter versions of the same. We need to be doing things that are substantially different than we have for the last 50 years in order to make a difference. So I will stop there. This is my contacts, and I will turn it back over to Annette.
Thank you, Professor Chorpita. Dr. Bower, if you could come on. Great. Now we're going to open it up to our guests and address as many of your questions as possible. And so if you do have other questions, please click on the Q&A window and we will try to answer them. Our talk so far has been so rich, and I do want to say that one attendee said, "Thank you, you are doing sacred work." And I just want to echo that. So let's start with some questions that were submitted in advance from our audience. This is an interesting one. Are popular therapies such as hypnotherapy, mushrooms, psychedelics, and marijuana safe and effective? Professor Bower, do you want to start with that? Maybe specific to people with cancer?
Sure. There is, this is an area of great lay interest, and especially in the kind of psychedelic space, right? We're hearing a lot about these therapies. They're getting a lot of press. I think there is some really exciting evidence that's coming out. And at least in terms of applications to cancer, I think we are not there yet. In terms of in the psychedelic space, I would say it's been interesting, actually, in my experience and the folks that I've worked with, and of course, Dr. Stanton, you work in this area too. A lot of folks are not necessarily interested in taking more medications, right? They are really looking to do something different, which is partly why we thought that mind-body approaches might be a good fit for that population. That said, in terms of marijuana and cannabis, that is something that I think has untapped potential in cancer patients. I think we're only starting to actually pay attention to use in that population where there is, I think a reasonable level of use. So I think that's something we're just beginning to understand and potentially try to exploit the promise of. So I feel like, people are using marijuana in the cancer community. That's in front of us. We need to really understand how that's helping them and how it can be implemented well. And I feel like our, the work on psychedelics it's still something I think we're trying to understand.
Thank you. And Professor Chorpita, do you have a response to that question?
Sure. Yeah, I guess I would say, so I don't study drug therapy specifically, but I can say a little bit about some of these things. But I can say more about hypnotherapy, which is a psychosocial therapy. There are 5 studies of hypnotherapy for children, 4 for enuresis, bedwetting, and 1 for test anxiety. And they're pretty weak. And again, remember, there's like 1,000 effective treatments for children's mental health, and there are many, many better options, but it's out there. And so, it makes me ask this larger question, which is why would someone consider, maybe it's just because they're popular and they're in the press, why would someone consider these as frontline? They're nowhere near anything that you would consider a frontline treatment for children's mental health. Given the wealth of really good options that we do have. Again, it's mostly the problem that people don't know about those. Why aren't people writing about those? I don't know. That's the problem I'm trying to solve.
Thank you. Here's another question that was submitted in advance. How can mental health and psychological science get a seat at the table when every television show every day has drug ads and they minimize the dangers of medications? Who wants to start?
You want to take that one first?
Sure. Gosh, that is a great question. And we could go well into the bedtime hours but let me say, like, if you look back, I showed that slide from Hawaii, and what that was like industry, university, government, community members, and citizens working together to make change. And that is rare and difficult stuff. Marketing is actually a good thing, or it can be. In academia, we market our ideas, but we don't really market our products or our actions. That's not our role so much. So we need these partnerships, and they're very hard to build. And if there are folks out there listening who are wondering how they can help with the children's mental health crisis, it is what can be done to foster these kinds of partnerships, because they don't happen on their own. And what happened in Hawaii was pretty extraordinary. It was because they were the worst system in the country at one time that folks came together in that way. So, if we want to make a seat at the table, we have to make our own table, I guess, and decide who we're going to invite.
I think for us, this is one of the reasons why I'm excited about this project that we're just hopefully starting soon. We're waiting for the notice of award from the National Institute of Health that would allow us to start our new study. But, I mentioned this partnership with this NCI Clinical Trials Network, and this was developed to test drugs. To my knowledge, I'm aware of 1, and there's maybe 2 or 3 behavioral trials that have been done in this network. So this is a place where I think psychologists and behavioral scientists have forced their way into the table through stewardship from our medical oncology colleagues who are sitting there and know that their patients need something more than the drug therapies, because the drug therapies don't address these symptoms. Actually, when I first started studying fatigue, people really thought, oh, it's going to be the psychostimulants that are going to cure this problem. As soon as we treat anemia, it's going to cure fatigue. None of those treatments work for fatigue. What works for fatigue is mindfulness meditation, cognitive behavioral therapy. And I think that realization has helped those folks realize the importance of behavioral science. So I think that's the initiative. There are these systems that are there for testing and disseminating medicine, and can we get access to those as behavioral scientists and psychologists?
Thank you. Julie, this is another question for you. Have you worked with transgender breast cancer survivors? And if so, is there do you differ in your approach to care?
Yeah, great question. So I'm not doing practice with cancer patients and survivors. And to be honest, until recently, this really wouldn't even have been a question that would necessarily have been on our questionnaires. So that's a problem in general in this area that we don't know. We don't know we don't know about prevalence of breast cancer. We don't know what are the screening guidelines that should be implemented. I was looking at a study, it was published in 2019. This is one of the first big studies of this, and they did find increased prevalence of breast cancer in, let's see, in transgender men relative to cisgender men. So this is something that's happening, and we've got to be trying to understand it so we get a sense of prevalence and figure out if these therapies are going to have effects across diverse populations.
Great, thank you. Now this goes to both of you, and it's related. So more broadly, can you both comment on the effectiveness of psychological interventions you've discussed so far in minoritized communities? Dr. Chorpita, do you want to begin?
Sure. It's sort of good news, bad news, I guess. It's better maybe than some people think, but I'll start with the bad news. So of the roughly 1,700 big clinical trials that have been done, 43% do not report ethnicity at all in their studies. So that might be shocking to some, but how can that be? But it is. So 57% do, however, and of those, about a third are representatively inclusive of African American families, and about a quarter are representatively inclusive of Latinx families. That doesn't mean they're purely focused on, but it means that they're substantially represented in those studies. So, but that's just talking about ethnicity. The question is about minoritized communities. So like where the field's going, where it is with gender identity and other aspects of identity are really, really lagging. The reporting is not good, and there's a lot of things we don't know. But I'll end with the good news, which is what we mostly find is that rather than this notion of we need to build different treatments for everybody based on the tremendous human diversity, what we seem to find mostly is that most things that work for most people, but may require some runtime adjustments or adaptations as they're going. How to do those is fairly complex. There's a lot of research going on about that, but most of what we have should benefit most of the folks that we know about, with some thoughtful adaptations.
Great. Here's a question from a UCLA alum who's now in Colorado and is a mental health counselor. How can we get involved in existing evidence-based modalities like the ones you both presented tonight as mental health counselors?
Well, that's a great question. So, well, how can you get involved? I guess if you want to get trained or know more, it is a matter of reaching out to folks who can provide that. So I should really put a link to that Margaret Crane paper or we should send that out. So there are, at least in children's mental health, the way this works these days is that there are typically organizations that scale these practices and models. And by getting in touch with those, you can learn how to do some of these things. Some of this stuff is even free. So there's some really nice organizations out there that provide training and support for these kinds of models.
Great. And Julie, the training question?
Yeah. So, I mean, I can speak really to our specific intervention, but then also more broadly to mindfulness-based intervention. So one of the nice things about the field of mindfulness is that they do have kind of teacher training programs so that you can learn how to, deliver these particular types of therapies. So there's a teacher training program for the MAPS intervention that's offered here at UCLA. And they've trained thousands of people, which is actually kind of one of the exciting things I think about this intervention is that, I mean, this is nothing to what Bruce is talking about, but in the world of cancer survivorship, if you have that many people who are both national and international, we get a lot of interest from people who are wanting to implement this program in other countries. So that's available. And there's two other kind of really standardized mindfulness programs. Mindfulness-based stress reduction, that's the original one. They have teacher training programs. And there's also mindfulness-based cognitive therapy, which has been tested in cancer survivors, shown to be effective. And these programs are standardized, they've been, and again, there's good teacher training for them all.
Great, thank you. And Julie, is the MAPS program effective for pain management? And a related question to what we've been talking about, how can someone out of state, this person's from New York, how can they find a program? A MAPS program?
So great question about pain. That hasn't been a major focus, at least of our research, because we're really focusing more on like fatigue, sleep, depressive symptoms, and haven't focused so much on musculoskeletal pain because we're not recruiting women specifically for that. We could. There's certainly many women who are on specific kinds of cancer treatments experience a lot of pain. But some of the first research on mindfulness-based stress reduction was done by John Kabat-Zinn for chronic pain, and the reviews definitely suggest that it's effective for pain. So I'm guessing that it would be that would similarly be effective in the field of cancer-related pain. Most of these training programs are now, this has been one benefit of the pandemic, right? A lot of this stuff is now available online. So again, there's mindfulness-based stress reduction that's centered, at least it used to be in Boston, University of Massachusetts, but you can Google mindfulness-based stress reduction training, and I'm sure there'll be a wealth of resources there.
Thank you. And we have a question from a marketing strategist and UCLA alum. The marketing strategist is curious about some ways to support you as researchers in scaling psychological science and digital therapeutics.
Yeah, as Bruce said, this is not as a scientist and a psychologist, I'm trained to test efficacy, right? Does this work? Bruce is at a different place on the translational continuum. He's like, we know it works. How do we get people? We want this to be used, and we want this to be scaled. So we're creeping along the translational continuum here. Bruce is further along than me in this, but you definitely get to a point where it's like, okay, we know what works. And how do we get it out there? So one of the things we've done is we're partnering with a digital therapeutics company. And my hope is that, great, this works, go sell it. And that is what they do, right? So this is, I think, Bruce, I'm interested to hear what you say about this, because you cross this, I think, more than many of us in psychological science. For us, at least, we're like, great, we've got a partner whose job it is, their financial model is marketing this product. And fantastic, right? That benefits everyone. They are really committed to developing evidence-based products for cancer survivors. So they're a great partner for us. But that's how we're trying to navigate that issue.
Bruce, do you want to comment on digital?
Sure, yeah. Just in general, I'll say it's great that marketing people would be interested in marketing something like psychological treatments. That's fantastic. And as I said, there's not an easy door to walk through and say, oh, how do I market science to the public? As I said, there are these mostly implementation organizations that do this now, and they're getting better at it. But for years, we did no marketing. We just built things and kind of went out in communities and tried them. And I think that's a flaw in our strategy. I think that we should be doing more marketing. At the same time, through partnerships. When you get too far from the science, it gets a little bit dicey there, right? So how do we set up a dialogue between these industries that are somewhat allergic to one another in a way historically? How do we get talking So I'm excited to hear the question. I don't have a great answer other than I would look to these implementation organizations as places to do that good work.
Thank you. Here's another question. How can we work to make psychological science and practices thrive in areas that have a lot of stigma about mental health care? Bruce, you want to start with that one?
Well, stigma, I mean, that's a marketing problem in a way too. So this Reaching Family study that you mentioned at the beginning of the hour that I'm doing with a colleague, Kim Becker, out in South Carolina, we are working on engagement and getting people involved in therapy. And we know that there's many reasons why people don't get involved in therapy, and stigma is a big part of that. So the other problem, we talked about the marketing problem, but if we have 1,000 treatments that work, but nobody wants them because they feel uncomfortable or embarrassed, or like it makes them feel bad that they need help outside their family, then we're not benefiting from all that good science. So we know a big piece in all of this is to manage the public's relationship with psychotherapy and all kinds of psychological science, which again, historically, it hasn't been represented well in the media. It hasn't been represented well in movies and television, and the public, has suffered as a result. So I think a lot of good work can happen in that area to make people feel more comfortable. These treatments feel really natural to people when families do get involved.
Annette, can I just jump in to
Please
say,
do.
so I think one of the things that is trying to happen to be implemented in cancer care is routine screening for depression. And so I think that's fantastic. But one of the problems is, oh, okay, you're depressed. Now what do we do? Right? You're this community oncology clinic. You're not designed to provide mental health services. So that's one of the things I think, there's a number of groups across the country that are trying to take advantage of, is like, okay, we got to screen everyone now. And then the next step will be, what is the digital therapeutic that you're going to be offered that's an evidence-based practice? This is something, I know our colleagues at Northwestern are working on. And ultimately, this is what we're hoping to do as well. So we're now, if we get this intervention, and this is just one example, right? But if this gets tested in this community oncology space, these are the folks who actually see patients. So perhaps it reduces the stigma to have the nurse that you've been working with be the one who's saying, hey, we always have you complete this depression measure. It looks like you're elevated. We've got an effective therapy for that. But if it's coming through, hopefully, the trusted medical professional, maybe that's a route in.
Great. I wish we weren't out of time, but we are, because I love this conversation. Thank you, both of you, for just a fantastic set of presentations and a conversation. And thank you all for joining us this evening. We hope you've learned something that you're going to take away. As Professor Chorpita says, we can all work on mental health. We will send you a post-event email with this link to the recording so that you can please feel free to share it with others that might have an interest. And we hope you'll be able to join us for our next Psychology Presents, which will be next month. Thank you so much for joining us, and thank you to Professors Chorpita and Bower. Good night.
Thank you.